Yeah. Good morning, everybody. Thank you, Dr. Indrani, for inviting me for this instruction course. I'm glad to be over here. So, after Dr. Divakan's talk about sutured SFIOLs, I'll be talking about ACIOLs. So, the topic is are they really recommended in presence of now the retrofixated iris sutured IOLs or the modern SFIOLs, and even with the evolution of new techniques like the Yamane technique, which has become pretty popular now. So, yes. So the management of IKEA has options of AC IOLs, the iris fixated IOLs, scleral fixated IOLs, uh, and the just a minute. Just I'll be sharing the power presentation mode. Hope my slides are visible.
Yes, sir.
Slides are visible, but we are not into the presentation mode yet.
Yes.
Slideshow, full screen.
Yes. Just. Yes. Sorry for that delay. Yeah. So. Let's begin with the history of evolution of antechamber IOLs. The antechamber IOLs came into scene fairly early in the history of intraocular lenses, and it was started soon after the Dr. Ridley used the first lens, and the first antechamber IOL was used as early as in 1952. So as the IOLs kept on evolving, the antechamber IOLs also kept on evolving. The initial IOLs uh, were closed loop haptic designs, and they had multiple complications like corneal endothelial decompensation, which led to pseudophakic bullous keratopathy, the uveitis, glaucoma, hyphema syndrome, and raised intraocular pressures, and also the cystoid macular edema. So these IOLs were primarily closed loop IOL designs of antechamber, and they had poor design, they had poor quality of manufacturing and poor polishing, and they had a lot of issues as not much was known about the sizing issues, and one size fits all technique was used for these IOLs. This often led to the fibrous tissue and pigments eroding into and growth into the holes of the haptic, and which caused synechia and raised intraocular pressures, and the IOLs coming close to the corneal endothelium. Now, over a period of time, there has been a considerable evolution in the design of these IOLs, and now the current IOLs are 4-point fixation, the Kelman multiflex antechamber AC IOL design, which is currently very well made with a polished surface, and there is no hole in the haptic, and a 3 or 4-point fixation technique, 4-point fixation to the iris and the angle structures is the current design. Okay, so this newer IOL has an open loop design with flexible haptics, and there is an anterior vaulting of 0.5 millimeter. This significantly reduces the pupillary block and the iris chafing and uveitis, which is associated with these IOLs. So even these IOLs are not foolproof because they're relatively contraindicated in patients who have pre-existing corneal endothelial disease, and there is pre-existing peripheral anterosynechiae. The chamber is shallow, or there is significant pre-existing iridectomy been done, or there is iris tissue loss. And in younger patients, especially, they are strictly contraindicated in pediatric eyes. So let's consider a scenario of coming across a young cataract surgeon who has just started his practice, and he's not confident enough to perform SFIOL as discussed by Dr. Divakan, or he doesn't have access to a good vitrectomy machine, or he's not confident enough. So in that scenario, if he has learned the technique of antechamber IOL implantation, that can save his day, because these IOLs are relatively easier to implant, provided we follow some thumb rules. So the anti-chamber IOLs primarily face problems because of the incorrect implantation technique. So these are a few scenarios, like this is a scenario of oversized anti-chamber IOL, in which often lead to the haptic which is coming out of the section of the implantation. Often the ACIOL, we see the many of times when we see complications with ACIOL, the IOL is often flipped or it's put upside down. Or in some cases, we also see a posterior chamber IOL, which is being labeled as ACIOL, but it's a posterior chamber IOL which is implanted in the anterior chamber, which is not an actual place to be implanted. So it's important that a proper procedure for the anterior chamber IOL being placed. So aim is to implant the anterior chamber IOL, which is well centered, properly sized, properly powered, and properly oriented, so that the haptic rests in the scleral spur. There is no eye stuck. The haptics are away from the iridectomies, and there is no vitreous in the anterior chamber or the bone. So coming to sizing, the proper sizing is important. It has to be the more oversized by 1 millimeter than white to white limbal diameter. However, we can't actually assess the appropriate size unless we implant it. Okay? So the sizing is a secondary concern, but it has to be 1 millimeter more in size as compared to white to white. And the most important is the correct orientation of implantation of the IOL. So this the picture on the left hand side is the current orientation, such that the trailing haptic bottom half has a reverse Z while implanting, and the knee of the trailing haptic is on the right hand side. Okay, so there has to be a reversed Z while implanting the IOL. So here we see this is the flipped IOL, or this is not the correct orientation on the right hand side, as we see. The ACIOL has a vaulting as well. So the ACIOLs are vaulted anteriorly, they are around 0.5 millimeter, and ensuring correct orientation ensures the correct vaulting, so which avoids the complications associated with like pupillary block, chronic uveitis, cystoid macular edema, and corneal decompensation. So here we see the ACIOL in the correct orientation. The side view of the Kelman's multiflex anterior chamber IOL. The top view is the correct orientation, so that the ACIOL has a vault anteriorly, and the lower one is the orientation in a flipped IOL. Okay, and this causes the complications associated with like raised IOPs, synechies, and all of the problems.
Doctor,
so I'm summing up.
Please request you to sum up.
Yes. So that so as I discussed, it is important to have proper technique and a review of comparing these two techniques of anterior chamber IOL implantation and the posterior chamber posterior scleral fixated IOL shows that these IOLs are safe, and there was no significant differences in the complications when long-term follow-up. And thus, in conclusion, the present-day anterior chamber IOL works well when implanted currently, and it compares well as compared to the scleral fixated IOLs. Though the scleral fixated IOLs may fare more better in long term, but it can save a day on a bad day for a young surgeon who has not learned the technique of scleral fixation of the IOL. So it's a good technique to have in one's current surgical armamentarium. Thank you.